evaluation of swallowing disorders. Who needs an evaluation of a swallowing disorder? Essentially, these will be patients with swallowing problems who are at risk of aspiration pneumonia. Examples of these patients are patients with neurological conditions, head and neck cancer, and these sometimes are complications of radiotherapy or surgery, patients who have recurrent chest infections, and sometimes simply patients who have frequent unexplained coughing and choking. Evaluation can be performed both in adults and in children. So how do we do the evaluation? First, we must understand the physiology of a normal swallow in order to understand and accurately diagnose a swallowing disorder. There are 4 phases during swallowing. The first phase is the oral preparatory phase, and this is where we put food into our mouths and we chew it. The second phase is the oral phase, where we use our tongue to manipulate the food bolus back to the back of the throat. The third phase is the oropharyngeal phase. And the fourth phase is the esophageal phase, where food goes down the esophagus into the stomach. The most relevant of these phases to us as ENT surgeons is the oropharyngeal phase. And the reason for this is that this is where the digestive tract and the respiratory tract intersect, and this is where the highest risk of aspiration occurs. So what are the steps that occur during the oropharyngeal phase of swallowing? The first thing that happens, once the vocal folds close, the soft palate then elevates, and this closes off the oropharynx from the nasopharynx. The tongue base then propels upwards and backwards, and together with this, the laryngeal elevators raise the larynx, and at the same time, the epiglottis flips over like an umbrella covering the larynx. When the larynx elevates, the cricopharyngeal muscle relaxes and the cricopharynx is pulled open. The pharyngeal muscles then contract, and pharyngeal peristalsis pushes the food bolus into the esophagus. We can see this with a corresponding number of endoscopic still pictures. So the first thing that happens is that the vocal folds close, and you can see the back of the larynx here. The tongue base then elevates, and the larynx then elevates, and a so-called whiteout occurs. So everything just turns white. The epiglottis undergoes retroversion, and the food slides over the top of the epiglottis like an umbrella. The epiglottis then flips back after the swallowing has taken place, and we can assess the cricopharyngeal function by looking at pooling in the hypopharynx. What do we actually see dynamically when we look at this with an endoscope? I'm just going to play the video. So I'm going to show you a dynamic view, dynamic endoscopic view of a swallow, and this is what you will see. So you put in the endoscope, and that's all that you see. So all of those steps that occur happen in less than half a second. And in fact, if you look at the picture, the slide on the right side, most of what you see is just a whiteout. And that is actually a good sign, and it implies that the swallowing is in good shape and is strong. What are we trying to find out during a swallowing evaluation? Firstly, we are trying to find out what is the risk of aspiration. Secondly, we want to know whether the patient can be fed safely. We want to know if there are any facilitative strategies that can improve function. And we also want to know whether surgery may be helpful for this patient. These are the modalities available to evaluate swallowing. Firstly, we can do a bedside examination. Secondly, we can do an endoscopic evaluation of swallowing. Thirdly, we can do a fluoroscopic examination of swallowing, or VFSS. And sometimes, if we need to evaluate the esophagus, we may want to do an esophagoscopy, such as a transnasal esophagoscopy. How useful is a bedside examination? It essentially examines two things. It looks at the response of the airway. So the patient is given some liquid to drink, and we examine whether they are coughing and choking. We also want to know whether the voice changes. Does it turn wet and gurgly? And these are all signs suggestive of aspiration. It is a useful screening test. So if you have a patient who takes small volumes of liquid and they have clinical signs, coughing, choking, wet, gurgly voice, then aspiration is likely. Some people will use auscultation with a stethoscope to listen to the sounds more clearly. But we will not go into the details of this. And this is because the flexible endoscopic evaluation of swallowing is currently the favored method of evaluating swallowing. It is favored because it gives direct visualization of the swallowing mechanism in the oropharynx. And essentially what we do is we put a flexible nasal endoscope into the oropharynx. We give the patient colored food and drink of different consistencies, and we assess their swallowing, and it can be portable. It can be done at the patient's bedside. It requires two operators, so typically I will do this together with a speech therapist, and we do a joint examination. It can be useful to assess facilitative strategies. What are facilitative strategies? These may involve altering the consistency of the bolus, changing the swallowing behavior of the patient. So for example, they may be asked to undertake multiple swallows, or sometimes they have to wash down food residue with thickened liquid. They may be asked to do postural measures such as chin tuck. And when I perform this examination in the clinic, the patient and the family are actually watching the examination on the screen, and the biofeedback can be very helpful, both for the patient as well as for the family and the caregivers. I hope this video will play. Yes. Okay, so this is just to demonstrate the role of thickening as a facilitative strategy. This is a patient who had a stroke, and this patient is given thin liquids. In the video on the left, there is what we call premature spillage. So the liquid is going all the way down to the hypopharynx, and the swallowing still hasn't been stimulated. The patient still hasn't swallowed. And when they eventually swallow, what you'll see is that a lot of that liquid enters the laryngeal vestibule, and there is a risk of aspiration. Now, if we thicken the liquid, this is what happens. So there's still spillage down to the hypopharynx, but we're using thickened liquid now, and when the patient eventually swallows, you can see that the bolus actually passes down into the esophagus much more easily. So this is one type of facilitative strategy. There are some studies examining the benefits of fees, for example, in patients after having had a stroke, and there is a significant reduction in pneumonia rates in patients who undergo fees. They are more likely to leave hospital on a standard diet because there is active intervention. And performing the fees and carrying out facilitative strategies can improve functional outcomes for patients after stroke. Fees can also be performed in young children and infants. For example, if they have feeding difficulty, noisy breathing with feeding, cyanosis with feeding. It has been used safely and effectively in children under 1 year of age. It is the only modality that can be used during active breastfeeding. Cooperation of young children during feeds can be an issue, but there is one study that has examined this and has found high success rates in young children for median age of 2 years. What about comparing fees with video fluoroscopic swallowing studies, which is the gold standard? So this is a picture of a video fluoroscopic swallowing study being carried out. And this was long considered to be the gold standard since the 1970s, but it is being overtaken by fees as the preferred option. It involves radiation, although low doses. It is cumbersome, and it is more expensive than just examining swallowing with the endoscope. So fees has the advantages of direct visualization, which we mentioned earlier. It's mobile, no radiation, and less costly. And we can also carry out sensory testing if necessary. A few years ago, there was an international consensus comparing fees and VFSS, and it showed that fees was slightly more sensitive for the presence of aspiration, more sensitive in detecting oropharyngeal food residue, and more easily used and more accessible. Video fluoroscopic swallowing studies can give better information, however, of the cricopharyngeal sphincter. This is a patient who has dermatomyositis and cricopharyngeal dysfunction. And you can see that when they try and swallow, the cricopharynx is not opening and the food is stuck in the hypopharynx. Eventually they swallow and the food passes through. In this patient, I carried out a dilatation and Botox injection of the cricopharyngeal sphincter. And after this is performed, you can see that the food bolus passes down a lot more easily. In fees, the cricopharyngeal sphincter opening is usually inferred by looking at pooling in the hypopharynx. So for example, this patient, and this is not a video, who underwent radiotherapy for nasopharyngeal carcinoma, you can see that there is significant pooling in the hypopharynx. We carried out dilatation, and subsequently the patient is able to clear the secretions better. And I'm just going to end this section of the talk with a case example of a patient who has aspiration pneumonia. Aspiration pneumonia, so the food bolus and the liquid is going into the chest, but the fees is normal. Okay, I need the picture up for this. And in this patient, what the video fluoroscopy showed was that the aspiration was actually due to a tracheoesophageal fistula due to mediastinal lymphoma. So this would not have been picked up because the pathology is lower than the oropharynx. And I'm just putting up this case example to show that video fluoroscopic swallowing studies and fees are often complementary.